everyone. Today we're going to be discussing ECG findings in hypocalcemia and hypercalcemia. If you have just joined the group, maybe you can help warm up the audience. Yes, but today we'll be discussing this topic because, just as a background, we picked these topics based on the Google Forms that we sent out before the program started, and we looked at we asked everyone, what do you want to learn? And we are basically focusing on the topic. So the flashcards may not come numerically ordered. It's just because we picked it from a deck of cards based on the topics you wanted to learn. So, but not to worry if you've just joined, we'll be sending all the links that's of the videos we have done during this challenge. We'll be sending it to your emails and any associated resource. We will be sending that. So I've decided to record this meetings because I think many people are not available when I'm available. Of course, we have participants from all around the world, so it just seems fair enough to record this session so that whenever you're free or less busy, you can go through them. Without further ado, let's dig in. Um, Today we are discussing this, like I have said, we're discussing calcium. Now, calcium is very important because it is a small but mighty electrolyte. It can easily go rogue. It can slow down the heart's electrical highway, and it can make the ECG scream. So it's therefore it's not to be toyed with. Hypercalcemia is when the calcium levels in the blood rise above normal. We already know this, and it can present as on the ECG finding you'll have shortened QT interval. I'm just going to move this a bit. So you would have, give me a few seconds to move away some of what's obstructing my view. Yep. So hypercalcemia, you would have shortened QT interval, you would have shortened ST segment. It's the most affected. The T wave may appear closer to the QRS. That's basically what the QT interval is anyway. And the Osborne J waves, if you've heard of it for hypothermia, it's also I call it the smiley wave, and I'll explain in a bit. But it's also something you can find in hypercalcemia, and the mechanism is that the high calcium in the blood speeds up phase two of the cardiac action potentially, if you remember your physiology. Um, so I've already explained what hypercalcemia means, and I'm sure you already knew that. But normally, your calcium level should be between 2.1 and 2.6. So if it's between 2.7 and 2.9, that's mild hypercalcemia. If it is moderate, that's 3 to 3.4. Severe is above 3.4, and this can be fatal. It needs urgent attention. It's an emergency. This will also come up when you're doing your 4H's and your 40's. If you're doing a resuscitation and you're looking for reversible causes, they tell you hyperkalemia, hypokalemia, or other metabolic disturbances because the issue with all these electrolyte disturbances are the fact that they can easily cause arrhythmias if they are not urgently controlled. And luckily, they can be reversed in the first few minutes of a cardiac arrest. So the common causes of high calcium levels when you have overactive parathyroid gland, a lot of people will present with high calcium levels, especially in the range of mild hypercalcemia in primary care. You would have people that have they will present for the first time. Many times they don't know they have cancer. They might just present with bone pain, or just feeling weak all the time, or bits like that, or having spasms, and that are non-specific. Really non-specific illnesses, lethargy, and they would come in with that, and you would do your bone profile for them. I mean, for those in primary care, especially, you would do your bone profile and you find elevated calcium. Of course, you want to make sure then that if you've done a bone profile, if your bone profile from where you work does not include parathyroid hormone, many times it doesn't. You then have to ask for your parathyroid hormone because this could be your first signal of primary or tertiary hyperparathyroidism. It could be in secondary hyperparathyroidism. Many times they have some kidney disease or some causes that you would be able to attribute to the high calcium. Now, certain cancers like myeloma or cancers that spread to the bone. So for the first time, they might present with bone pains. So if you have a patient, for instance, that has bone pains or has prostate cancer, the first site of metastasis to the prostate cancer of prostate cancer is to the backbone. And so if they're having bone pains and you happen to do maybe an ECG for something else or a routine ECG, and you're noticing ECG changes, it's probably in the moderate to severe hypercalcemia range, and you need to correct it quickly so that you do not have them getting more unwell while under your watch. Now, of course, very some people do drink too much milk. Some people overdose on antacids. That can cause the milk alkali syndrome. Some people have sarcoidosis, which is an inflammatory condition that can cause hypercalcemia. Sometimes the first thing you will see in a patient with sarcoidosis is that they have this erythema nodosum. They have these ardent red areas in their shin area, in their calves, and they do not even have. Sometimes they may have respiratory problems, sometimes not. And so it's just important for you to keep, when you're seeing your regular patients, there's so many patients that the first thing we are not doing for them is not an ECG, because our differentials are quite broad if somebody comes with unspecific weakness. But it's a good thing to think about an ECG, especially if they're acutely unwell. If they have too much vitamin D from supplements, they could have hypercalcemia. Now, to the nitty-gritty of everything, which is the ECG, which is the reason why we are having this conversation. So, in hypercalcemia, you will have, like I said, you will have a shortened QT interval. Now, where is the Q and where is the T? So, we know that this is our P. We know that this is our Q. We know that this is our R. We know that this is our S. And we know that this is our T wave. So if this is your P, actually your QT interval starts from here to here. Now, this is your QT interval, right? Now, your QT interval in hypercalcemia is short. As a rule of thumb, I always like to explain that even if your own printout in your hospital or where you work does not calculate the QT interval or the QTC for you, what you expect in a normal ECG is for this QT interval, right? This QT interval to be less than half. So let's assume that this was a continuous ECG. You want this to be less than half of this RR interval, because this is 1 hour, this is another hour. So your QT interval, normal QT interval, should just be less than half. I always like to say less than about 40%. It's a rough gauge. It's not the most accurate measurement, but it works every time. If you're having your QT interval becoming really small, less than 30% of the entire RR interval, you should have another look and try to really calculate the QT interval, right? So you have shortened QT interval, and in your hypocalcemia, the reverse is the case. You have a widened QT. And so here, in many cases, the QT interval, in fact, in all cases of prolonged QT intervals, what you have is that the QT interval is more than half, more than 50% of the entire RR interval. And so what we want to do, what are the clinical implications? Why is this important? This is important because, this would commonly result in arrhythmias. We know that torsades de pointe is a big fear with electrolyte disturbances. Suddenly, you have your polymorphic ventricular tachycardia, and then that can deteriorate very quickly into a ventricular fibrillation. And also, it is monitored in malignancy, hyperparathyroidism, vitamin D. So it's common in hypercalcemia is common in quite a number of conditions that are very frequent. I know that I have picked up quite a number of hyperparathyroidism. Of course, they did not have severe hypercalcemia, but simply by having high calcium consistently and checking their bone profile, checking their parathyroid hormone, I've been able to pick many cases of that. Then, of course, increasingly, we're having a lot of cancer in patients. And sometimes the first inkling is not a particular mass or is not the kind of symptom that you're looking out for in your red flag. Sometimes it's just something with their bloods. And so, especially when you have things like multiple myeloma or things that have to do with bone profile or bone metabolism, you really want to be looking at the electrolytes. And to be fair, in many cases, your first inkling is not even the diagnosis, it's the bloods, it's the ECG. And so we are going to be looking at this particular ECG. As you can see in this ECG, what is the QT interval looking like? It's quite difficult to make out the QT interval in this ECG because, as you can see, there's bizarre QRS complexes. There are bizarre QRS complexes. Um, so I'm trying to figure out how to further annotate this. But as you can see, there are bizarre QRS intervals. There is the QT, which is shortened. So when this is what I was trying to explain to you, if there's 2 hour intervals here, and this is the QT is really quite short. And what is normal QT interval anyway? We know that QT intervals in women should not be more than 460. In men, it should not be more than 440. And sometimes we can even be forgiven up to about 20 milliseconds more. But when it's becoming more than 500 in either sexes, then that's just a totally no-go area. In this patient, they had a QT interval of about 260. And, of course, that is very short. So they have a QT interval, you have a shortened QT interval. Also, in terms of the Osborne waves, the J waves. Remember here that in this slide, we did mention that you have a shortened ST segment. You have sometimes it can be rare, but you will have your Osborne J waves. You have your shortened ST segments, which is the most affected. Now look at this ECG. Look at your ST segment. This is your, if we said this is your R and this is your S and this is your T, the ST segment here, I mean, you might not appreciate it very much because this is actually the S. And here, what you have is the J wave. The J wave is not very classical here for us to, but again, you could make out the J wave here. And this is how I like to explain it, the smiley phenomenon. So there's a smiley face here. So as you can see, it's a very subtle J wave, but it is there. I've seen much more lovelier J waves. So you might not be able to make it out completely here, but you can see there's a J wave. The J wave is present at the J point. Now this is the J point, but the wave, the upsloping that we find here. Now you can find J wave also in benign, what looks like a J wave also in benign early repolarization. You can find it in other cases, but in this setting of a shortened QT interval, this should make you think of hypercalcemia. Now, when you look at yes, this is another one here. And in this case, again, you're having bizarre QRS complex. You can barely make out a T wave, if you agree with me. There is a T wave. It's just that the T wave, and you can find it, this is the T wave here. The QT interval is so short, the ST segment is so short, it's super short, that what you would have here as your QT interval is so short. If this is the distance between the RR wave and this is your QT. This is about 25% or less than your entire QT interval. And this should, because normally it should be about 40% of your entire QT interval. And that should be your first signal. That's just a kind of cheat code. But actually, that is what it would be. So in terms of a shortened QT interval. In hypocalcemia, we discovered that we've told you that the reverse is the case. In hypocalcemia, the QT interval gets longer. The heart is like, whoa, 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 I need time to recover. I need more time. So you have a prolonged repolarization phase. You remember what the T wave means? T waves means that the ventricle is repolarizing. They are slowly recovering from the electrical impulse. So when they are slower than normal, it's because there's low calcium in the blood. And why does this matter? Because we know that low calcium slows down the reset phase of the heart cells. The ECG shows a long QT from a longer ST segment. And the real life clue is that the QT is really dragging. It looks like the heartbeat is dragging. Both long and short QT intervals are dangerous rhythms. You should know about both, really. So as you can see here, like I inscribed in this is your T here, and this is your Q. There's not a very obvious Q wave here, but this would be your Q. Now your QT here, and look at this is your RR interval. Your QT is way more than half of the entire RR interval, and this should signify you. So when you count the number of boxes there, you would find out that this is more than 460 milliseconds, getting towards 500 milliseconds, because of course, as you can see here, the QT interval is way prolonged. We've told you that greater than 460 in men can be a problem. And you in your QTC, in fact, the reason why we are the one that alerts us more towards that is more prone to causing a tosadis to point polymorphic type ventricle is actually your hypocalcemia because the QT keeps getting stretched. So hypocalcemia and prolonged QT interval is what is what we often link the most to tosadis to point, and it can cause syncope, seizures, sudden cardiac arrest. It can be seen in hypoparathyroidism. It's basically the reverse of hypercalcemia. So consider checking ionized calcium if ECG changes are present, because you really want to know how many of the ionized calcium particles are present and are affecting the delayed electrical conduction in the heart. Now, in this ECG, what do we find here? If we look at our rhythm strip, we can barely make out a T. But if you agree with me, if you look very closely, there's what looks like a T here, there's what looks like a T here, there's what looks like a T here. And in this case, you can see that the QT interval is way more than half. In this patient, I'm trying to recall who this ECG belongs to, but in this patient, I believe this is one of the patients that had a calcium of about 1.2. I mean, this is an emergency. You need to urgently replace the calcium. And when I mean urgently replace, you follow your standard protocol, will monitor. When I mean urgent, I mean in terms of how seriously you take this, not in terms of being overly rushed with any medication. You have to intervene quickly, right? And how you yes, and here you can see your T wave inversion in your AVL. You can see your T wave inversion in other places. In your you can see some. Ideally, the T wave should be flat, and indeed they are indeed flat in lead 2, in lead 3. But they're up. They're quite upright in V2. But the classical things with hypocalcemia is that you would find your flattened T waves. Now, just a quick, yes, this is another one. Yeah, of course, there are no J waves. We talked about J waves in the setting of hypercalcemia. But here again, you can find what is your QT segment here. Your QT segment is way more than half of your RR interval, right? And so this should signify to you that there is a problem here with the calcium. You have low calcium levels, so you have, yeah, it looks like there is a sinus rhythm. However, there's prolonged QT interval, and this could happen after a thyroidectomy. They've had their thyroid glands removed, and inadvertently they've had some of their parathyroid glands chopped off as well. And so here you have poor metabolism of calcium, and you have hypocalcemia. And this is about 0.5 seconds, as you can see, about 500 milliseconds here as well. Because if you have this and you count 1, 2, 3, 4. Hello? Sorry, I did have um sorry, it seems there was some internet disruption, but we go back to what I was trying to explain. So if we know that, if we count the number of small squares let's actually count them this time. So if you check your QT interval here, just roughly that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. This is about 12 and a half small boxes. And 12 and a half, if one small box is 40 milliseconds, that's 0.04 seconds. So 0.04 seconds is 40 milliseconds. So if you have 12.5 small boxes times 40, 12.5 small boxes times 40 would give you 500 milliseconds, because one small box is equivalent to 0.04 seconds. So, and which is 40 milliseconds. So that tells you definitely here that this is a prolonged QT, because the max you should have in a man, we say is 460. Sometimes we give an allowance of an extra 20, especially if they are stable and there are no other red flags. But if they are getting to a 5 to 500, then you really do not want to um, waste time any longer. So in hypocalcemia, you look out for prolonged QT intervals. In hypercalcemia, you look for shortened QT intervals. And just as a recap, there are several electrolyte abnormalities, but in any unwell patient, what you want to do is to make sure that you have an ECG, if especially even if they are non-specific symptoms, but as long as they are acutely unwell, I always think it's safe, in addition to bloods, in addition to vitals, in addition to actually checking your patient, which should be your quick airway, breathing, circulation, disability, exposure assessment. In addition to your quick A to E assessment, you should be able to do an ECG. You should be able to do an ECG as well. And if you have any questions, please put this in the group. I think that we have come to the end of this presentation. Don't forget that in terms of hypercalcemia, the first thing you want to give is your IV fluids. Step one is always give your IV fluids 0.9% normal saline. Step two is you want to probably add a diuretic, but not too soon. You could do your loop diuretic, but only after rehydration. Remember that thiazides are a no-no because they increase calcium. Then you will now want to talk about your biphosphonates if you've not been able to achieve any significant improvement with your hypercalcemia. Because, and in hypercalcemia, just think about it. There is bone breakdown and it's releasing calcium into the blood. And, so there are calcium outside the cells. And if all of this has not worked, you might want to consider your calcitonin, but this is, you leave that up to, to specialists to decide how they want to take that up. And of course, they might want to treat the cause. If it's an hyperparathyroid problem, they can consider surgery. If it's myeloma, metastasis, sarcoidosis, vitamin D toxicity, you want to treat the root. Now, for the treatment of hypocalcemia, you know that you are giving your 10% calcium gluconate. You are replacing the calcium. And the additional thing that this does is that it stabilizes the cardiac membrane. So you want to give 10 mils over 10. And that's why, I mean, even though you're intervening urgently, it doesn't mean you're rushing in the medication. That's far from it. What I mean is that you have taken note of it and you're acting quickly. But in terms of medications, you're still giving quite slowly, right? You're giving them very slowly, and fix the cause, fix it. Sometimes if it's just mild hypocalcemia, you're just giving oral calcium, oral vitamin D. Remember that hypocalcemia will go together with hypomagnesemia. So you might be pouring water into a basket if you're not treating hypomagnesemia in the context of hypocalcemia. Do have a great day.